everybody. Welcome to the Dental Handoff. I'm Dr. Kelly Tanner. I have with me the one, the only, Tom Viola. Tom, what is up, my friend?
Ellie, how are you? It's so good to see your face. It's so good to get the time to talk. You and I are two ships in the night. We see each other in a hallway of like a convention center. Hey, Kelly, and then and off we go. So it's good for us to be
Yeah.
one time. Yes,
So,
talk.
Tom, you're so popular. You're everywhere, and you guys, I've been trying to get on Tom's schedule for a while. So I'm so honored that you're here to talk with our audience about your path, what you're seeing is happening. Leave us with some pearls of wisdom. But first, we always start with why dentistry for you? Like, did it choose you? Did you choose it?
The origin story, as any good superhero has.
Yes.
So I'll keep mine brief, okay, because it's not that impressive, really. I started out as a pharmacist, and that's what I did for about 10 years. And then started to get a yearning to do something more. Pharmacy was great. It was a good career. It helped me in my early life, but I felt like I needed to educate more than anything else because it just was this need I had to sort of give back. My professors were so good to me in school, and really, they realized I was born with a small capacity brain, so they took extra time to make sure that I understood concepts. And so when time came, I got an offer to teach at a hygiene school, pharmacology, and I'm still there, by the way, all these years later.
Wow.
It's going to be like 28 years, I think. And after that, it was just one more school, one more school, one more school, and then somebody said, "Hey, you know what? Uh, I work for this dental office, and my dentist really wants an update on pharmacology. Can you do it?" And that's how speaking started. And from there, webinars, podcasts, and all of a sudden, here I am. So I can't say it was a very fascinating story. But I will say the one thing that I love about the story is that I've really been surrounded by good people.
Mm.
I've had one dentist who really taught me dentistry, more than I could have learned on my own. And his approach, because this was New York City, so don't be offended. It was like, look, stupid, you don't know anything about dentistry. I don't have time to teach you dentistry. So I'm going to do all the talking, and you're going to do two things. One, keep your mouth closed, and two, keep your ears open.
Mm.
You know what? He taught me dentistry in a way I could never learn it myself. He taught me everything I needed to know and nothing else. And so that became my mantra as a speaker in pharmacology. I know I can spend 3 hours boring people to death with drug interactions and contraindications and all this stuff, but what I really aim to do in my lectures is give people what they need to know and nothing else.
That's what we need. We need it that chair side. You're like our personal flip chart, Tom.
Yeah, and I
We
hope.
just hear your voice.
Yeah, I hope to do that. Yeah, and that's one of the things I feel good about my career, and that I know people out there may have my droning nasal Brooklyn accent ringing in their ears, but at least there's some information in there as well.
Well, you're such an entertaining speaker as well. You're definitely not. I mean, you're not full of. You're full of indications and contraindications, obviously, but you're you contextualize them, and so they're applicable to our everyday. Of okay, what do I need to know? What else do I need to be asking the patient?
Yes.
What are some of the things that have been the most surprising to you over the years that um, maybe people aren't asking?
Okay, so what I've learned also is I've served as an expert witness in litigation,
Mm,
and criminal and civil. To be honest, I mean, more civil than anything. And what I've learned is how important the chart is, and you live and die by the chart. So I tell all my audiences the same thing when I first get started. You can forget everything else I've said in a lecture and learn it again, but if you don't walk out with this message, I didn't do my job. And the three words must ring in your ears: document, 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 document everything, and document it the same day. Because if you think you're going to do it tomorrow, trust me, you're gonna lose some of the nuances. You're gonna lose some of the facts. You're gonna lose some of the things you were talking about with that patient, and then it's not in the chart. And if it's not in the chart, it never happened.
that's right.
And so that's what I tell all my audiences now. Beyond the documentation, and I tell them, I don't care if you write it in hieroglyphics. I don't care what language you write it in. Just get it in the chart so that later I can say, well, here it is in the chart.
Hmm.
Beyond that, it's what you put in the chart that matters, right? So, did you take a complete and accurate medical history? Hard to do, Tom, in a 45-minute appointment, but yet you must. And I hate to be, the one that brings this up, but have you taken the vitals, blood
Hmm.
pressure? pulse. I mean, these are, standards of care. I mean, yeah, I don't say we all don't do it, but I'm not saying we all do it. So
Yeah.
those are things that are important because not just from a litigious standpoint, but it would be, right? So if someone's looking at your documentation who's not a dental expert in any way, not expert in dentistry, all they have as a background is medical backgrounds. Every time I go to my doctor, even if it's for a referral, what do? They take my blood pressure. We should be doing the same. Why aren't we? I mean, that's the main indicator of disease that we can use that's easy to identify, easy to access, and yet it tells us so much
Mhm.
about the patient.
Yeah, it's the number one cause of death,
Absolutely.
cardiovascular disease, and if we can screen for it, it's what I tell hygienists internationally. They get hung up on, "Oh, the blood pressure cuff isn't as accurate," and I'm like, "Listen, you're screening. You're not a cardiologist. You're screening." If you wanna take it again, what'd you learn in hygiene school? You wait a few minutes and you take it again, or you go get the blood pressure cuff, the real one that you have in the closet if you need more time, but
Yeah.
that's how you save lives.
And we teach, I mean, I teach at all these schools. I mean, we teach taking blood pressures and pulses on patients. So why do we forget when we get licensed? What happens there? What's the disconnect? And of course, as I tell everybody, it's to your benefit as well as the patient because if you take their blood pressure every time, you get a baseline, right? You know what their blood pressure is normally. So if today it's well, now you can ask questions. Hey, what's going on? Why is your blood pressure so high today?
Mhm,
And that's the kind of stuff. Think about it. You see a doctor as a patient once a year if you're lucky.
mhm.
But you see your hygienist or dentist more times than that, twice a year sometimes. So in the end of the day, if we're taking blood pressures twice a year and the doctor, medical doctor is taking it, maybe once a year, who's really screening their blood pressure? It's us, not the doctor. So
Right, exactly, and a lot of folks don't realize that 120 over 80 isn't healthy anymore.
not at all.
Yeah, and so it's a opportunity to educate with starting just where you are.
Yeah, and
So
when you've got that little chart that tells you, okay, blood pressure equals this blood pressure equals this. But the one thing they don't tell you about the chart is what I say is ask the patient first, what's your normal blood pressure? Because
yes.
pressure's 90 over 60 and you show up at 150 over 100. Well, that's not, stage 2 hypertension for you. That's hypertensive crisis for you. So that's what it means. It means you've got to know the patient sometimes better than you know a family member.
Yes, and that's why I asked them, "Is this normal for you? Is your doctor aware?"
Yeah. Yep.
And they're like, "Yep, it's exactly where it needs to be. It's adjusted with my medicine. It's normal that it's higher because it's usually this without medication."
Yep.
Write all that down, right, Tom?
Absolutely. Document everything. And I'll tell you something between you, me, and everybody else who's listening, there's no reason why a patient should have hypertension in your chair. Because if they've been diagnosed and medicated for it, then they should be taking their medication and it should be close to normal. So if it's not, it could be white coat. I mean, I've heard that many times, but bottom line is if it's really elevated and it's been elevated 3 times you've taken it every 5 minutes, there's something more going on there.
Mhm.
So honestly, that's the ticker right there. That's the thing that gets your attention and that draws you in. Like, okay, what's going on with this patient? What do I need to know? Because that could be a medical emergency. The stresses of a dental appointment, we're used to it, but patients aren't used to that kind of stress, and they're white knuckling the whole time. And that's a ticking bomb for me. If a patient's got advanced cardiovascular disease and they're in denial about it or don't know about it.
Yeah, because it doesn't hurt. We can explain it away, right?
Yes, exactly.
We just say, "Oh, I got up too fast," or, "Oh, yeah, I haven't been feeling exactly right, but I think it's this."
Yeah.
And, we're really good at that as humans.
Yeah, very good. Yeah. Yeah.
What are your favorite things to talk about, Tom? Like, when you're out on the circuit, what are some things that, light you up, like your top 3 things? I know that there's so many that but, like, the audience goes, "Nuh-uh." What are they?
Yeah, no, there's a lot to talk about there. So a lot of it is the hidden gems of medications, the talking points that you can take back with you. So just for an example, when I talk about proton pump inhibitors, the drugs that we use for heartburn, even though it's not really heartburn, it's gastroesophageal reflux disease, but we all call it heartburn because that's what the TV commercials call it. And, it's the food's fault. It's the food that does it, not me. I'm fine. It's the darn spicy meatballs that cause the problem. But what I'll say is, patients use these drugs, SSR, PPIs, proton pump inhibitors, and H2 antagonists like Pepsin and Zantac because they have heartburn. But that decrease in stomach acid means you can't absorb enough calcium. Can't
Mm,
absorb calcium, that means you have poor bone homeostasis. Poor bone homeostasis equals poor osseointegration of an implant. So wait a minute, you mean drugs that people use every day, like Nexium and Prilosec and Zantac, can cause a patient's dental implant to fail? There's 3 studies out on it now. I
Mm,
mean, there could be more, but that's a gem. That's something that you take with you and say, "Hey, I've never thought outside the box like that." It's always bisphosphonates
yeah,
but these drugs are and a lot of these drugs are over the counter, so if they don't tell me they're taking them, how would I know?
right.
So there's one, and then, by the way, SSRIs can cause it too. SSRIs interfere with osteoclastic function, which again, same thing, poor bone homeostasis, poor osseointegration. So how many people take, Lexapro and Prozac? That's a lot of people
A
who
lot
could
of
be
people. Yeah.
so right there, I mean, those are the things I like to talk about. And then I like to talk about some controversial stuff too. Some of my favorite topics are cannabis or marijuana.
Mhm.
Wow, there's so much that dental professionals don't know about cannabis, uh, and it's not their fault. They were never trained in cannabis. They didn't learn about it in school. Well, not as a subject in school. That's a whole other.
Right. Yeah, yeah, yeah.
So, you know, how many people know that cannabis raises your blood pressure and pulse? I'm outside, I'm a patient, and I'm thinking, "Yeah, I really don't like this dental experience, so I'm gonna, smoke a joint or whatever, or take an edible to take the edge off." But now I walk in and my blood pressure and pulse are elevated. They think, "Oh, I'm using this to take the edge off, so I'm gonna be nice
The
and,"
opposite, yeah.
and it's the opposite, right? And so who knew that? That's but so why it's controversial, it's not the fact that marijuana is controversial, or cannabis is controversial. It's controversial because it's probably the one drug your patient knows more about than you do.
Mm.
So how could you keep up as a dental professional? That's why, I like to add as much content as I can in that course just to give people the historical perspective, the legality, why is it legal in one state, not the other? But also, what it means to dentistry. What are the clinical dental considerations?
Because I talk to a lot of docs, they say, "Why wouldn't I want my patient to be high?" Because they're relaxed, I have a
Uh,
compliant patient, no anxiety, I continue on with what I'm doing.
yeah.
Some are they taking blood pressure? I don't know, but then, how does it react with the local anesthetic as
Right.
well?
You got a 20-year-old who comes in and needs, minor work done. You're thinking to yourself, I'm not taking their blood pressure. They're 20 years old. But meantime, they're the ones that had the 3 Starbucks for breakfast, the 2 energy drinks in the
Yeah,
middle of the day, and, smoked some cannabis out in the parking lot before they walked in for their appointment. Of course, their blood pressure is screaming high, but if you don't take blood pressures, you wouldn't know that.
yeah, so you're the front line of defense. We really are.
Yeah, but both for the patient and yourself, because that could be very litigious. Because if that ever goes to it, let's say that the patient says, "Well, the doc never took my blood pressure, the hygienist never took my blood pressure, and because of that, I suffered that stroke." Well, how can you defend yourself against that? You
That's
can't.
right. You know what I always find interesting, Tom, is that when you look at, I'm not sure, I'm looking at staging and grading all the time with the grading, and it talks about tobacco and diabetes, the A1C
Yeah.
levels. I think there's so much more that they can add to that. What are your thoughts on that? I mean, it doesn't, the risk factors of a patient don't just rely on two things. I mean, biofilm, in addition to that, there's, like you said, the marijuana, the vaping,
Yeah.
what are the other things that we can add to that? So I kinda have some a gut feeling that they are going to update that. What are your thoughts?
So the thing is, 50 years ago, let's put it this way: this is all deja vu. Okay, that's what I call it, deja vu. Meaning, 50 years ago, we were at the forefront of a battle with a substance we knew very little about, but everybody used. It was called tobacco. 50 years
Mhm.
later, we're at the forefront of a battle with a substance we know very little about. It's called cannabis. So just that alone is the huge deficit right there for us. But to your point, and if you don't mind me taking it a step further,
Please.
Tom, don't be so darn focused on high blood pressure and taking blood pressures. There's a lot more to talk about, like A1C. How many people know their A1C, or know their fasting blood glucose? How often do you go for a metabolic panel and get that done? I don't know, once a year? And if you're lucky, if you see a medical doctor once a year. But hygienists and dentists know what they know. They can see the signs, right?
Mhm.
They can see the friable blood vessels. They can see, how a patient reacts to stress and are they getting, hypoglycemic, you know more about the patient than they think you know.
Right.
So that's when I say look for the signs, look for that thick mucinous saliva that's always an indicator, right? Look for those blood vessels that, that just seemingly break on their own for no reason. And then look for other things like the varices in the back of their throat or the damage to their enamel, because that's a sign of GERD. My point here is that dental professionals can save lives because basically they save people from themselves. People make bad choices. One of those choices is they don't ever see a doctor. But you see the signs of disease, and now all of a sudden you make that comment like, really should see a doctor about this. I think you have reflux disease. I think you have, cardiovascular disease. I think you have the early stages, if not pre-diabetes, of diabetes.
Mhm.
Now's the time, right? You saved their life because you've made a decision in their mind, a positive choice. Like, okay, maybe I should see my doctor. Now, when I say this, sometimes dental professionals say to me, "You know what, Tom? I don't have time for this. I don't get paid for this. Okay, I'm not their medical doctor." I get that, but I also get that when you say it, it matters to them, matters to the patient because they look at you like, "Well, you don't have a horse in this race. Why do you care? Obviously, it must be important. Why else would you mention it?" So they,
Right.
you know,
Yeah, they d the and the herbal supplements and, turmeric and all of those things and how it increases, prolonged bleeding time, it's you don't have your clotting factors there, and they just don't think to report it to you because they just think it's just something that they take that's for wellness that maybe they read about, and we know more than we think that we know. It's what I always try to get back to is we learned a lot about risk factors in hygiene school. So if you're seeing something, what's going on? It's not just about the effect of it, but what's the true problem? What are the risk factors that are there? Back up, tie it to their medical history, ask different questions because to your point, it's may not seem related and they may say, what why are you asking me all that? But it's that trust that you're building with the patient because we get them 2 hours a year, to your point, at least, and we only get them 2 times a year to say it in a different way.
right,
So
right.
to bring things up that they don't know about, it's what I told my patients yesterday. They're like, "I had no idea that I was missing here or had all this plaque there. I'm using a Sonicare, I'm using this, and it's about angulation." And, "Oh," the light bulb goes off. It's like, "But this is why you're here. You know better, you do better."
Exactly. As students in dentistry and in dental hygiene, you learn all about stratifying risk. It's all about, assessing risk. And so it's important to know that you really have to know the person, as best you can. Now, okay, so people say to me, well, how do I get a medical history, Tom? They don't even want to tell me. They don't even think I need to know because I'm working in their mouth. They don't think I need to know their blood pressure, their medical history. And
Right.
this is where I think I try to prove my worth. And I say, you don't need to take a complete and accurate medical history, sit there with a clipboard and wait 20 minutes. And, now you got 20 minutes to get your job done to wrap up. Uh, Just ask them to give you a list of things they take, right? Over the counter drugs, dietary supplements, prescription drugs, everything they take. And with a working knowledge of pharmacology, you could fill in the medical history yourself. And then you could just some very pointed questions like, okay, I see you taking Norvasc. Why do you take that? Because it could be used for multiple things, right?
Right.
Hypertension. So you take 5 minutes, ask those very pointed questions, and then you've got the whole medical history. So, as I've always said, if you want to know something about somebody, find out what drugs they take, and it'll fill in most of the blanks for you.
Yeah, I think she was a 42-year-old female yesterday. She was on no medications, and you could tell she was so anxious. And during the appointment, she started, like, ripping the chair, and "Are you okay?" And she's like, "I'm fine. I was just thinking about my mother and something that she'd recently been through." And so it doesn't even have to it's us recognizing the small things that could also lead to an event.
Yeah,
I know that we're good at that, right? This is one of the reasons why we're in this profession is so we can notice all those little things about patients, but to ask more questions about it, to then put it in the chart and to say this could and I think ask more questions of them, like, how often are you thinking about this? Are you seeking help for this? Because this is something that you need more support for in your life if it was something that was traumatic. She didn't really want to talk about it, but she started becoming very anxious in my chair and started not complaining, but making comments about the way things tasted or the way they sounded all of a sudden.
yeah,
And I thought, okay, anxiety is definitely, I was like, do we need a break? And please, your choice. You tell me what you need, but it's all of those little things that establish that trust that keeps them coming back, and it saves their lives because if they're getting ready to have some type of event, at least you're picking up on the little things that help them out long term.
Yeah, and then I tell this to my students all the time and my audiences, when the patient's in your chair, they're basically a victim. They have no control over the situation. They just lie there and let you do what you want to them in one of the most sensitive parts of their body with mental instruments. And they can't see what you're doing. If you were doing hand surgery, at least they could watch. You're in like what I call the chamber of secrets, right? They don't know what goes on in here. And then you're in there. So everything you do in there is a surprise to them. Like, what's that? What's that? So if you look at that and see, okay, well, what would be one way to diffuse that situation? Don't make them the victim. Give them the hand signal, as I always say. Okay, I'm going to do this now. It's going to feel like this, and when I'm done, give me the thumbs up or the thumbs down. If you need a break, well, give me a thumbs down, and we'll take 5 seconds. If you thumbs up, good. So what you've done there is you put them in the driver's seat, right?
Mhm.
Tell them everything that's going to happen before it's going to happen, and that just builds confidence because they're saying to themselves, "Okay, she said this was going to feel like this, and it did feel like this. So now I can trust them because they're going to tell me when something's really painful. I'll know about it in advance. Plus, the thumb up or down, I'm in control now. I'm telling you what to do, and that really takes the stress down."
Yeah.
'Cause I don't feel like this victim anymore. I'm not white knuckling the chair anymore because 'cause I'm in control of the procedure, and that matters, but if you don't think of it from that perspective, if it's just another body in the chair and you just gotta get your work done because, you you lose that perspective.
Maslow's hierarchy of needs is safety. You need to feel safe.
Yeah.
We want to feel respected by what we're doing, but if someone's safe, that trust is never going to be there. So psychological safety, we all need that as humans. I mean, if you think about the culture of work and where we choose to work and surround ourselves with our friends, that's what we want. We want to be able to say what we want to say and be and do, and so it's giving patient that autonomy back over the appointment. And some patients will say, "I don't want to know what you're doing. Just do whatever you need to." I had one on Wednesday that said, "I wanna know everything. I'm OCD." I'm like, "Oh, you're speaking my love language."
Uh, yes, exactly. Well, that's it. The other thing is you and I both know this as speakers. We always go to these big meetings, and there's always courses there inevitably that say, "How do you hold on to your current patients? How do you retain your patients? And how
Mhm,
do you attract new ones?" I can't think of a better way than to, be as upfront and transparent as possible, take them out of the victimhood, give them the thumbs up or thumbs down, hand rule, and really make them understand that you're there for them more than they're there for you. And
mhm.
once you do that, the word's gonna spread. Like, "Hey, you gotta go check out my hygienist or my dentist. They're amazing." That's how I think word of mouth works, and I think sometimes because we get so busy during the day, we forget those principles just because, you work in a dental office, you work on an island.
Yeah,
And if you do everything the same day on the island, you're never gonna do anything different until somebody else comes along and says, "You should be doing it this way." So, that's why I think, come to courses like ours, and you'll learn to look at things from a different perspective, as well as new information and education, and that makes all the difference.
yeah. So I know you mentioned, marijuana and edibles and things like that. What are some other cool things that you're seeing coming that or maybe that you're already speaking about that people may find interesting that we didn't learn in school?
Definitely, prophylaxis. That is one of the hot topics right now, Should I really prophylax, with antibiotics for infective endocarditis? I mean, we learned about it in school, like, well, should you not? But now things have changed over the years. And if you're even out of school 10 years, it's changed twice already.
Yeah.
In my mind, for infective endocarditis, it's not even it's not a no brainer now because been studies have published that have said, two that I'm aware of that said what? It really works, that invasive dental procedures can cause bacteremia, which can lead to infective endocarditis. And it's important to use prophylaxis to prevent them. But the guidelines changed because what is a procedure? Well, every procedure we do in dentistry, right? But what is the predisposing factor? And very few people have the types of things that the guidelines say you need to prophylax for,
Right.
right?
Right.
So it's if you look at it from the 10,000-foot level, oh, anybody with a congenital heart disease, got to give prophylaxis. Anybody with prosthetic heart valve, got to give. Slow down. Look at the guidelines, and they're much more specific than that.
Mhm.
But now, if you flip the screens over to joint replacement infection, there's absolutely no justification in the research, zero. But how many of you have a patient, orthopedic doctor that says, "Give my patient amoxicillin for the rest of their lives," and it is
Yeah.
do? Like, when does it stop? Yeah, there's no evidence. But do you really wanna be the one to deny the patient that antibiotic when their orthopedic doctor insists that they take it? So the higher calling here for us is stewardship. And I'm not saying we shouldn't be stewards of antibiotics. We don't want resistance, but at the same time, it's got to be a patient by patient decision. And believe me, I get burned on this all the time in social media. If you read some of my social media, people always, you're perpetuating myths, Viola. And I get it, but at the same time, it's a patient experience. You've got to look at everything from a case by case basis.
Yeah. A lot of docs are just referring to their orthopedic surgeon or their cardiologist to give them that clearance because the docs are just want to be taken out of it. They just want a medical clearance form from their doc saying, and they're telling them this is considered an invasive procedure. I mean, this is what we teach at hygiene school,
Yeah,
right?
yeah, yeah.
Um, Calling to get a medical clearance for my patient with the we're doing an invasive procedure. They're like, "Oh, you're just doing a cleaning? What are you doing?" They say, "Oh, you're just doing a cleaning. That's fine."
Sure.
But wait, what? And it that part kills me. That's a whole other topic. But
I agree.
um, paying attention to the research. So prophylaxis, cannabis. I know you speak. You're quite passionate about Ozempic and the other GLP-1.
Yeah, yeah. There's a lot going on there, and that's the thing. To just go back to our other point real quick, and people say to me, "You're always asking for consults. I don't have time for consults. Viola, consults, consults, consults." Yeah, but here's my point on that. I'd rather get a consult because at the end of the day, if I end up in court over this, I don't want, and a medical doctor is subpoenaed to show up for that case. I want that medical doctor sitting on my side of the courtroom, not their side of the courtroom, pointing fingers at me, saying, "Never called me." So if that helps in any way justify the time you spend on a consult, so be it. Now, to go to the point of Ozempic, I'm not against using Ozempic for weight loss. I think it's a great idea. It's all about getting healthy. So why not? I think the problem is, and just from my perspective, it's not Ozempic. It's called Wegovy. Wegovy is the GLP-1 agonist that's that's called semaglutide for weight loss. So why is everybody talking about Ozempic? Ozempic is the same drug, but it's used to treat type 2 diabetes.
Mhm.
Why isn't everybody talking about Wegovy? And the answer is because Wegovy is not covered under their insurance. It is.
Ah,
So now I've got a question. How did your doctor end up prescribing Ozempic for you if you don't have any of the risk? Oh, maybe you are pre-diabetic. See, that starts the conversation.
yeah, yeah.
And,
And
and
how
that-
did you know? And how are you monitoring that? And what are the lifestyles that what have you done? What are the other things you've done to change your lifestyle and educating them about the oral systemic link, bringing that together?
right,
Amazing.
right, and keep in mind, somebody can tell you I'm on Ozempic, but they didn't tell you they bought it from their neighbor, they got it overseas, it's potentially counterfeit. All I'm saying to you is, I use Ozempic. So you got to ask more questions now. Like, why are you on Ozempic? And if it's for weight loss, why aren't you on Wegovy? And where someone's going to eventually fess up and say, well, I got it from my neighbor. They're pre diabetic. They don't use it. So they gave it to me and I gave them, a free pass to the beach this year. Okay. But I need to know that because
Yeah,
now you're self medicating. See how quick that was?
right. Yeah,
Yeah.
because it needs to be monitored
Agreed. Yeah.
for that.
So hypoglycemia is a real enemy for us in dentistry. We all know that. So that's why it's,
Absolutely.
yeah.
This is so interesting. I have so many more questions for you, Tom. Well, I mean, if you want more, I mean, obviously you can only get like a little snippet of time right now, but he's out on the lecture circuit. I know he does some podcasts. But Tom, thank you so much. Any final words that you want to offer the audience?
My best pearl I can give anybody who's listening to this podcast is, first of all, thank you, Kelly, for the opportunity because
Mhm.
that I enjoy this opportunity to just sit down and talk and not speak, right? To just have a conversation. But my advice to anybody who's listening is, if you're a dental professional out there, remember that you've got to document everything. Vital signs are not your enemy. They're called vitals for a reason. And a medical history is gold because it gives you more ammunition and more intellectual power to understand a patient and understand what's the best treatment plan based on their medications and based on their individual needs. And that's what really we're all about. We're all about delivering good care, good dental care, and safe dental care. But if you don't know the patient, you can't make those decisions.
That's right. Because you can't put two and two together. And I find when people say, "Ah, the patient didn't believe me or didn't value," or they said it cost too much or whatever that is, My rule of thumb is, did you bring it back to their medical history to have them understand the link that it truly is that's there for them, for their livelihood to live?
Every time.
And
Yeah,
and did they understand that? Because if they understood that, then they're still making that decision, then, they need the information to make a decision, and that's what we're giving them.
exactly. Well said.
Yeah. Well, thank you, Tom, and, I'm sure I'll see you out and about. Thank you for all that you do for
I
everyone.
thank you for what you do for dentistry, Kelly. You're amazing, and I've always said to myself that if I ever run into you at some point and we can grab a cup of coffee, we could probably, spend 3 hours chatting about everything we're gonna talk about and what we're gonna say to our audiences, but, this was great. I appreciate the opportunity.
Absolutely. Thank you. And to our audiences, thank you so much for what you do every day, touching the lives of people who are right in front of you, healing hands. And, I always ask the favor to go on over to Apple Podcasts to give the Dental Handoff a 5-star rating because Apple's the one that matters. And if you're watching this on YouTube, please go ahead and push the like button and subscribe so the algorithm recommends the podcast to others who may also love it. So we will see you soon, my friends. Thank you, Tom, and I'll run into you soon, hopefully.
Looking forward to it. Thanks, Kelly.
All right, be well, everyone. Bye bye.